Hi friends, this is Dr. Mayur Kulkarni. I am your radiology faculty. Let us look at a few radiology related questions which were asked in the recent NEET-PG 2023 exam. Now this was a pretty standard chest x-ray based question. A patient presents with fever and cough since 5 days. On auscultation there are creps which were heard on the right side. The radiograph here reveals what? Now there's obvious, if you look at this chest x-ray carefully, you can see that there is an obvious haziness or a fluffy opacity in the right paracardiac area, right? You are supposed to look at this particular opacity and come to a correct diagnosis, which particular lobe is involved or what the underlying pathology is. Well, this question is straight away an application of the Sillout sign. Before we go into Sillout sign, let us quickly discuss a very important concept on which the Sillout sign is basically based. And what is that concept? That concept is the concept of differential radiographic density theory. What does this theory tell us? Simply put, this theory tells us that on any radiograph of any part of the body, mind you, this does not just apply to chest x-rays, but rather any radiograph of any part of the body, this theory tells us that in the human body of the various densities which are present, only and only 5 tissue densities can be identified separately from one another. On any radiograph of any part of the body, only 5 tissue densities can be seen separately from one another. What are these 5 densities? The least dense component of the body is the air density. Where is the air density present in the body, especially in the chest? We are looking at a chest x-ray here. It is the lungs. The next density which can be identified separately is the fat density. If you watch very carefully, this is the subcutaneous fat which can be seen separately here, right, from the adjacent tissues, different, slightly more dense than the air density there. The next group of density is the widest or the largest category of density, and that is water density. What is water density? So all the soft tissues in the body, except fat, because fat is a separate density, we have already seen that. So all the soft tissues in the body other than fat have a uniform density, that is the water density. So if you look at the heart, it is water density. If you look at the diaphragm, it is water density. If you look at the abdominal soft tissues, it is water density. If you look at the muscles around the bones around the humerus here, it is water density. If you look at the chest wall muscles, it is water density. All these soft tissues other than fat is water density. The next separately identifiable density is the densest tissue component of the body. What is that? It is bones. So as you can see here, these bones we are able to identify as a separate density, right? Separate from the adjacent tissues. So it is a separately identifiable density. Another density, right, that this theory states can be identified separately is the metal density. Now, where is the metal density here? If you look at the next density that can be identified separately is the metal density. Where is the metal density? See here. Now, if you look at this particular radiograph, if you look at this particular implant or fixation plate within the clavicle, right, it is a metallic plate. Can you see how dense and separately identifiable it is from the adjacent bone itself? So this is a separately identifiable density, right? So the differential radiographic density theory tells us that these are the 5 densities, tissue densities, that can be identified separately from one another. Now that we have seen the theoretical basis of this theory, let us see how we can apply it practically and what is the Sillout sign. Now, the Sillout sign, pretty simply put, is that whenever you look at a chest x-ray, right, you need to identify certain sharp margins. If you look at this radiograph, can you see a sharp right heart border here? Yes. Can you see a sharp left heart border? Yes. Can you see a sharp right dome of diaphragm or hemidiaphragm? Yes. Can you see a sharp left dome of diaphragm or hemidiaphragm? Yes. Can you see a sharp margin of these bones as well? Yes. Can you see a sharp margin of the aortic knuckle or the right upper mediastinal border? Yes. Now the question is, why do you see these sharp borders or margins on any radiograph? Based on differential radiographic density theory, right, what it states is that whenever there are two tissues, whenever there are two tissues of different radiographic density, two tissues of different radiographic density, then in between those tissues we can identify a sharp margin. Why do we, or when do we see a sharp margin on a radiograph? Whenever there are two tissues of different radiographic density that lie immediately adjacent to each other. Let us look at all the sharp margins that we see here. Now look at the sharp right heart border. What is the density of the heart? We just saw the density of the heart is water density. What density lies immediately, adjacent to the heart in the right paracardiac area? It is the air density within the right middle lobe, that is the right paracardiac area, that is the part of the lung there. So two tissues of different density, that is air density and water density, when they lie adjacent to each other, right, in between them we see a sharp margin. Why do we see a sharp margin of the diaphragm? Because diaphragm is what density? It is water density. What lies just above the diaphragm is again air density within the lungs, that is the lower lobes predominantly there. That is the reason why we see a sharp margin. Now therefore on any chest x-ray, remember that whatever sharp margins that you see, that is the aortic knuckle, right upper mediastinal border, right left heart borders, right left domes of diaphragms, you are able to identify these sharp margins only and only because just adjacent to these structures there is the normal air density within the lungs. If any of this lung would become abnormal, right, and it would change its density to water density, then that particular margin would be lost. How is this? Look at this particular radiograph now. In this radiograph, and this was the radiograph which was asked in the exam, right, what you see here is that there is a hazy kind of a shadow or an opacity in the right paracardiac area. Now what is this right paracardiac area? This right paracardiac area over here, this is the affected area. This has taken up a water density. So because it is consolidated, what is consolidation? Consolidation is when air within the alveoli is replaced by fluid, right? So normal lung has air within the alveoli, so it has air density. When this air within the alveoli gets replaced by fluid, it becomes consolidation. So the density of a consolidated lung is water density. So this part of the lung is now water density, whereas over here you can see the right heart border or the heart per se is also water density. Now the heart is water density, immediately adjacent to it the lung is consolidated, it is also water density, right? So in between them, look at this radiograph carefully. Tell me, are you able to identify a sharp right heart border? No, the right heart border here, which should have been visible over here like this, is not seen. Given that a particular sharp margin which is always seen on a chest radiograph is not seen here, this is what is called as the positive Silaut sign, right? Which part of lung is involved here? It is the part of the lung which lies immediately adjacent to the right heart border, and what is that? This is nothing but the right middle lobe. So this is right middle lobe consolidation, and this was the answer to this particular question, in this particular in this question in this NEET-PG exam. So it was right middle lobe consolidation. Now see, whenever a question on Silaut sign is asked, you tend to look at a chest x-ray, you look at the opacity or where it is located, and you look at what adjacent margin is lost or it is not seen, right? It is only when that a particular margin is lost or obscured or not seen that is called as Silaut sign positive. Now thus when you identify a particular margin which is lost or it is blurred or it is not seen, look at the adjacent lung. What lobe is located over there in the adjacent lung? That is the lobe which is affected. Now when you try to solve questions on Silaut sign, it is essential to know the basic lobar anatomy of the lungs. For this we need to draw the fissures. So what are the fissures within the lungs? There is a horizontal fissure on the right side like this, and there is an oblique fissure which is located like this. Above the horizontal fissure you have the right upper lobe. In between the horizontal fissure and the oblique fissure you have the right middle lobe, and this was the one affected in the question that we just discussed. because the right middle lobe is the lobe which is located in the right paracardiac area. So if the right heart border is lost or not seen, the disease would lie in the right paracardiac area, that is the right middle lobe, and the part of the lung that lies below the oblique fissure is the right lower lobe. On the left side, there's only one fissure over here like this, and that is the oblique fissure. Whatever part of the lung that lies above the oblique fissure is the left upper lobe, which also includes the lingular segment that lies in the left paracardiac area. So lingular segment is a part of left upper lobe. Remember, there's no middle lobe on left side, but there is a corresponding anatomic segment, that is the lingular segment. And whatever part of the left lung that lies below the oblique fissure is called as the left lower lobe. Right, now let us look at the various margins that we need to identify on the along the right mediastinal, along the left mediastinum, or the right lung, left lung, and what particular lobes could be affected. So if you look at the right sided ciliates or margins, if the examiner is telling you or showing you that the right upper mediastinal border is obscured, then what is the lung which is located adjacent to it? Right, just draw the fissure, the horizontal fissure, the oblique fissure. So what is this lung lobe which is located above the horizontal fissure, which abuts the right upper mediastinal border? We already discussed this. This is the right upper lobe. If your examiner is showing you, as was in this NEET-PG exam, that the right heart border is not visualized, right, then the disease would lie in the right paracardiac area. This is the part of the lung that lies between the horizontal fissure and the oblique fissure. What lobe is this? This is the right middle lobe. If your examiner is telling you that the right dome of diaphragm, right, is obscured, then most of the right dome of diaphragm is lined by the right lower lobe, but some part of it towards its medial aspect is also lined by right middle lobe. So if the right dome of diaphragm is obscured, the disease is more likely to be in the right lower lobe, but occasionally it could also be in the right middle lobe. So that is how the questions are going to be asked on seal outside. This was the question which was indeed asked this time. Now suppose your examiner is trying to show you a pathology which is located in the left lung. So a particular margin on the left side would be obscured. What could those be? Now before I go to these margins, I want to quickly revise the segmental anatomy of the left lung, because this is going to help us. If you look at the left lung from the sides or from the medial aspect, this is how it would look like. This is anterior, the diaphragm dips down, so this is posterior. On the left side, in the left lung, there is only one fissure, that is the oblique fissure, which runs from posterior superior to anterior inferior. So in front of it, you have the left upper lobe, below and behind it, you have the left lower lobe, right? What are the various segments now? In the left upper lobe, you have a segment which is called as this is called as the apico-posterior segment of the left upper lobe, and this segment is what is called as the anterior segment of the left upper lobe. Now the left lower lobe, I want you to realize, is like a pyramid. So there is a superior segment sitting on the top, there is a anterobasal segment, right, anteriorly at the base, there is a posterobasal segment posteriorly, there is a medial basal and a lateral basal segments on the either side. So 4 basal segments and a superior segment sitting on its top. Why are we discussing this? This is because I want you to know this segmental anatomy with respect to how the course of the aorta is. We all know that the ascending aorta is anterior, that is how the aorta originates. Then the arch goes posteriorly, and the descending thoracic aorta is posterior like this, isn't it? So this is how the course of the aorta is, isn't it? Now suppose you look at a chest x-ray and I tell you that this sharp margin of the aortic knuckle is not visualized. If this margin of the aortic knuckle is not visualized, can you tell me, looking at this schematic diagram, if the aortic knuckle is over here, which lobe, which segment is abutting it? What is that segment? It is the apico-posterior segment of the left upper lobe. So if the aortic knuckle is obscured, then the disease pathology is going to be in the apico-posterior segment of the left upper lobe, right? Now just see, below the aortic knuckle, you can see a sharp margin of the lateral margin of the descending thoracic aorta. So if the sharp lateral margin of the descending thoracic aorta is not seen, then look which segment and which lobe is going to abut this descending thoracic aorta. What is it? It is the, yes, it is the left lower lobe. Which segment? Either the superior segment or the posterobasal segment. See, superior segment is here, posterobasal segment is here, right? So if the lateral margin of the descending thoracic aorta is obscured, then the disease is going to lie in the left lower lobe, either the superior segment or the posterobasal segment. This is something that we are able to see directly in this schematic diagram that we have drawn here, isn't it? Now, if the left heart border is not seen as a sharp margin, then the disease would lie in the left paracardiac area. What is the left paracardiac area? It is the lingular segment. It is the lingular segment of left upper lobe. We've already seen that. And if the left dome of diaphragm or left hemidiaphragm is not seen as a sharp margin, then the disease is located in the left lower lobe. All right, now what we have seen here, we are just going to revise quickly. Now see, this is a question which has been asked in this exam, right? We've emphasized before in our routine videos, in our revision MCQ discussion videos as well, is that this is a very high yield topic. A lot of questions have been asked till date as was asked. Now it's very likely that going ahead you might be asked a question on this. So let us quickly revise. If the right upper mediastinal border is obscured, I've put an arrow there. Which part of lung is involved? It is going to be the anterior segment of the right upper lobe. We have seen this because horizontal fissure is like this, oblique is like this. So this part is located above the horizontal fissure. It is going to be the right upper lobe. If the right heart border is obscured, right? If the right heart border is obscured, then the disease is going to lie in the right paracardiac area. We've already discussed this. This is right middle lobe, and this was the answer to the question in this NEET exam. If the right dome of diaphragm is obscured, then we have discussed the disease is most likely going to lie in the right lower lobe, but it could also sometimes lie within the right middle lobe. Yes, on the left side, the left-sided coelot, just remember the schematic diagram that we just drew. If the aortic knuckle is not seen as a sharp margin, then the disease is going to lie in the apico-posterior segment of the left upper lobe. Right? If the lateral margin of descending thoracic aorta is not seen as a sharp margin, then the disease is going to lie in the left lower lobe. Which segment? Superior segment. So superior segment and the posterobasal segment. So superior segment and the posterobasal segment, we've drawn the schematic diagram for this. If the left heart border is not seen as a sharp margin, then the disease is going to lie in the left paracardiac area, which is nothing but the lingular segment of left upper lobe. And if the left dome of diaphragm is obscured, then the disease is most commonly going to lie in the left lower lobe. So this is all you need to know about coelot sign. Let us quickly apply this, what we have studied, and try to crack a few chest x-rays going ahead. Look at this chest radiograph here. You can see a opacity in the right upper zone. Where the opacity is, you're not able to see a sharp right upper mediastinal border, and if the right upper mediastinal border is not visualized, the disease lies just adjacent to it. What is this? This is right upper lobe involvement or right upper lobe consolidation, as is seen by its sharp inferior margin. What is the inferior margin of right upper lobe? It is nothing but a fissure. What is that? It is nothing but the horizontal fissure which is forming the sharp inferior edge of the opacified right upper lobe here. So this is right upper lobe consolidation. Now watch carefully here. You can see an opacity in the right mid to lower zone. If you watch very carefully where the opacity is, right, you are not able to see the right dome of diaphragm. But if you watch very carefully through and through this opacity, you can very nicely see a right heart border. If the right heart border is seen very well, it means that the right paracardiac area is normal. That is, right middle lobe here is normal, but the right dome of diaphragm is obscured. So which lobe is commonly involved when the right dome of diaphragm is obscured? It is the right lower lobe. So this is going to be right lower lobe consolidation. Look at this, there is a opacity, haziness in the left paracardiac area, and wherever the opacity is, the left heart border is not visualized. If the left heart border is not visualized, disease lies in the left paracardiac area. What is the left paracardiac area? It is nothing but the lingular segment of left upper lobe. This is the lingular segment of left upper lobe consolidation. Yes, now look, another opacity that looks to lie adjacent to the heart, looks as if it is adjacent to the heart, right? But if you watch very carefully, you are able to see a sharp left heart border. If the sharp left heart border is visible, it means that the left paracardiac area, that is lingular segment, is normal. If you look at this radiograph carefully though, the left dome of diaphragm is not visualized, it is obscured. If the left dome of diaphragm is obscured, where the disease lies? The disease lies in the left lower lobe. So this is left lower lobe consolidation. So see how easy it is. When you look at a particular chest radiograph, you just look at a few sharp margins that you must always be able to identify. That includes the right upper mediastinal border, right heart border, right dome of diaphragm, aortic knuckle, lateral margin of descending thoracic aorta, left heart border, left dome of diaphragm. If any of these margins is missing, then it means that the lung which lies immediately adjacent to it is affected. How to localize that? We have just seen this. This is what is Sillaud sign based on differential radiographic density theory. Yes. Now look at this question. This was also a repeat. Basically, a patient presented with dull aching pain in the back and sterile pyuria. So this is a clue your examiner is giving you, right? So this is a clue. This is a clincher of a diagnosis, that is sterile pyuria. His KUB radiograph is shown here. What is the most likely diagnosis? So what do you see on a kidney, ureter, bladder radiograph? You're able to see an opacity, a calcific opacity in the region of the right kidney here, right? Now, what could this be? Can it be a staghorn calculus? A staghorn calculus is a calculus which basically is formed by a cast filling out the entire pelvic callicial system. So the shape of a staghorn calculus is actually like the horns of a stag, and it has a branching appearance because it is actually filling up the pelvic callicial system. This calcification or opacity that you see here though does not appear like a staghorn calculus. It is like the shape of a kidney, and it is as if the entire kidney is being calcified. And this is something that happens very peculiarly in one condition, and that is genitourinary TB. And what is this calcification of the kidneys occurring in TB called as? It is called as putty kidney. So what is this? This is basically a putty kidney. Why is this not nephrocalcinosis? Nephrocalcinosis is usually focal calcifications within the kidney. So nephrocalcinosis is actually focal calcification within the kidney. Either it can be cortical, or it can be medullary, or it can be both. It is not a diffuse calcification like this. Psoas abscess would be located somewhere within the psoas. These are the psoas shadows on both sides, can you see, on which the kidney is actually resting. So we have ruled out the other options. This is a diffuse calcification involving the kidneys. What is this? This is nothing but a putty kidney. Right now, putty kidney or genitourinary tract TB, right, is also an absolute favorite of your examiners, right? So these questions, at least 2-3 questions have been asked in the past few years. Let us look at some classic clinchers of genitourinary tract TB. What is the most characteristic clinical feature? This was there in this exam, in the history the examiner had given you. And what is that clinical feature? It is sterile pyuria. So sterile pyuria is a specific clinical clincher for a diagnosis of genitourinary tract TB. What is the best modality for early diagnosis? The best modality for early diagnosis of GUTB, remember, is intravenous urography. If they use the word early diagnosis, then and then only the answer should be intravenous urography. Why is it so? The reason is that in the early stages of genitourinary tract TB, the affection is predominantly involving the callisis. And which modality helps us visualize the callisis? It is intravenous urography. There is erosion of the callisis, giving rise to a specific appearance of the callisis, which is called as moth-eaten calyx. And which modality, which imaging modality helps us look at the callisis? It is intravenous urography. And therefore, for early diagnosis, it is the best modality. But overall, if they ask you, if they don't use the word early diagnosis, if they just ask you what is the overall best investigation, then it is a contrast enhanced CT scan. Remember, overall best imaging modality for diagnosis is a CACT. What is the most common CT finding? The most common CT finding, if your examiner asks you, is renal parenchymal calcification. Remember, renal parenchymal calcification is the most common overall CT finding. The most valuable radiologic feature in genitourinary TB is the multiplicity of findings. So at the same time, you will see multiple findings throughout the genitourinary tract, some involving the kidneys, some ureter, some the bladder. What are these findings? Let us have a look. Now, this genitourinary tract TB is indeed a treasure trove of MCQs. So that is the reason why this is an absolute favorite of your examiners. Right, let us start with the kidneys. So in the kidneys, what can you see in the early stages? We'll look at some radiograph, IVU as well as CT images as we go ahead. In the early stages, do you remember I just told you what is the modality for the best earliest diagnosis of genitourinary tract TB? It is IVU. Why so? Because I just told you that in the earliest stages, what is affected? It is the calyces which are affected. So there is an erosion of calyces. There is an erosion of renal calyces. This gives rise to a distortion of the normal shape of a calyx, and this calyx is called as a moth-eaten calyx. So this is called as a moth-eaten calyx. This is one of the earliest findings that you identify in the kidneys in genitourinary tract TB. There could be extracalyceal accumulation of contrast. So what happens once the calyces is eroded? The contrast spills out from it, and there is extracalyceal accumulation of contrast. There could be hydronephrosis because of the debris which is produced because of tissue destruction, may block a few of these calyces, and there could be hydronephrosis. In the late stages of involvement, right, this was the image which was given in your exam. What happens? Renal calcification, diffuse renal calcification, and this is what is called as the putty kidney, right? Ultimately, when a kidney is so diffusely calcified, it is not going to function well, isn't it? So what the body does is that the blood supply to that non-functioning kidney is gradually cut off. The kidney becomes calcified, shrunken, and non-functioning. This phenomenon is what is called as autonephrectomy. So these are the findings that we see in early and late stages renal involvement. Now let us see what will happen if the ureters are involved. Because of the long-standing inflammation, the ureteric valves get thickened, they get fibrosed. So a renal pelvis might be pulled up. That is what is called as the hiked up pelvis. Because of the wall fibrosis, there might be kinks or twists within the ureter. This is what is called as the Kerr's kinks, or it can give rise to a corkscrew or kinked ureter, right? The ureteric wall becomes thick, fibrosed, dilated, and this is what gives rise to your pipe stem ureter. Right? What would happen is that the ureteric orifices become, appear like a hole when they are viewed, by a cystoscope, by passing a camera, into the bladder. This is what is called as the golf hole ureter. Now, what happens to the bladder is a similar thing that happens to the ureter. Because of the chronic inflammation, the bladder wall becomes thick, right? The capacity of the bladder is decreased. So this urinary bladder wall becomes extremely thick, the capacity is reduced, and this is what is called as the thimble urinary bladder. So these are all potential questions that could be asked maybe in an upcoming exam based on genitourinary TB. Now let us look at some classic images. If you look at this intravenous urography image, I want you to look at these calyces. Look at the normal shape of the calyces here, and now compare these calyces with these renal calyces. These renal calyces have lost their shape. If I zoom it up, see, look at this calyx. This calyx has an irregular outline. Why? Because it is eroded. This is what is called as your moth-eaten calyces. So this is what is called as a moth-eaten calyx or moth-eaten calyces. This is the earliest finding or the earliest change which is happening at the level of the calyces. So IVU is better able to detect it. So it is the imaging modality of choice for an earlier diagnosis, right? Again, once the calyx is dilated, right, the contrast may spill out and there could be some extracalicial contrast accumulation which could be seen. Putty kidney, we have seen, is a dense uniform calcification, dense amorphous calcification of the entire renal parenchyma. The kidney is non-functioning, it is cut off, leads to autonephrectomy. So this is what is called as putty kidney. Ultimately, we have seen that the bladder becomes extremely small, right? So the bladder becomes extremely small, thick-walled, fibrosed. This is what is called as a thimble bladder, along with dilated ureters. These are what are called as the pipe stem ureters. The orifice of these ureters into the bladder at the UV junction is called as the Golf hole ureters. So these are the various imaging findings in genitourinary tract TB. Now, speaking of one infection of the urinary tract, let us also quickly discuss and revise another possible infection that they could ask you, and that is schistosomiasis, bilharziasis of the urinary bladder. The most important differentiating factor between them is that TB involves the entire urinary tract, isn't it? We have just seen it. We have seen the features that would be seen when the kidney is involved, selectively ureter is involved, bladder is involved, the entire tract is involved, whereas schistosomiasis involves only the urinary bladder. Only the urinary bladder is involved, right? Why? Because the eggs of the parasite are laid along the vessel walls in the wall of the urinary bladder. So there is an inflammatory response. The wall gets chronically inflamed, it becomes thick, right? The bladder capacity is shrunken, and this is what may over the long term give rise to the calcification of the wall of the urinary bladder. So this gives rise to the fetal skull-like appearance, fetal skull-like appearance of the urinary bladder. This chronic irritation of the UB wall also predisposes in schistosomiasis, predisposes to the development of squamous cell cancer of the urinary bladder. So that we have covered genitourinary tract TB, but along with that, now we have covered another infection. This could potentially be asked as a question going ahead. Remember, only urinary bladder is involved, not the kidneys and the ureters in schistosomiasis. Fetal skull-like appearance of urinary bladder might be seen because of chronic inflammation and calcification. It predisposes to the squamous cell carcinoma of the urinary bladder. So this is all you need to know about schistosomiasis, right? Now look at this particular question. A 2-month-old infant came with a parietal swelling since birth. What is the most likely diagnosis? Honestly, right, this is not, something which is done very routinely in the radiology department. When you see a swelling over the scalp or the head in a newborn or in a child, most of the times the diagnosis is clinical. It may be related to the birth or birth injury, right? Most of the times diagnosis is clinical. Very rarely a skull radiograph is done. Rather, skull radiographs per se nowadays are considered to be obsolete. We advise not to get a skull radiograph done, right? Because it gives us very little information per se. But this was actually an image which was asked in your exam. So let us quickly discuss these pediatric head swellings per se, or cranial swellings: cephalohematoma, caput succedanum, subgaleal hematoma, and cephalocele. Let us try and distinguish between them. Let us quickly discuss what they are, and then we will go to the question and what the diagnosis was. So what is a cephalhematoma? It is a hematoma. But where is the hematoma? It is just below the periosteum. So it is subperiosteal hematoma. So it is under the periosteum, above the skull bone. Because it is under the periosteum and periosteum ends at the cranial sutures, cephalomatomas are limited by suture lines. What is caput succedanum? It is nothing but subcutaneous serosanguinous fluid collections. Where is it located? It is in the subcutaneous spleen. It is clear serosanguinous fluid collection. What is a subgaleal hematoma? Again, it is a hematoma. Where it is? It is subgaleal. So it is below the galeal aponeurosis of the scalp, but above the periosteum. Right? So look at the difference, right? There is a huge potential space, right, below the galeal aponeurosis, overlying the periosteal surface. So that is where this subgaleal hematoma is. What is encephalocele? Encephalocele is actually the herniation of intracranial contents, herniation of intracranial contents through what? Through a defect within the skull vault, through a defect in the skull vault. So developmentally, the skull vault is not well formed. There is a hole in the skull vault through which the meninges, brain, blood vessels may herniate out. So this is technically nothing but a neural tube defect. So this is a neural tube defect. Now this is what these conditions are. What is the cause? Cephal hematoma. Why should there be a hematoma? There will be an hematoma when there is some injury or trauma, isn't it? So this is usually a result of instrumental delivery, instrumentation, right? So instrumental delivery like ventouse, vacuum application, or forceps. So this causes trauma and therefore there is a hematoma. Caput succedanum is seen in normal vaginal delivery. It is because of the pressure of the presenting part against the cervix, which results in some fluid collection in the subcutaneous plane, disappears very quickly. It is seen in normal vaginal delivery. Subgaleal hematoma, as it is a hematoma, when will an hematoma occur? Only when there is some trauma. So again, this is a result of instrumental delivery or instrumentation during delivery. So again, ventouse or forceps, right? Encephalocele is what? It is a neural tube defect, I said. So this is nothing but a developmental defect or anomaly. So developmental defect or anomaly. Now, what is the clinical presentation? Thus, cephalomatoma presents as a focal swelling, right? So it is a focal swelling limited by suture lines because it is below the periosteum. Caput succedanum, right, can also be some focal swelling, right, which may disappear very quickly, right? Subgaleal hematoma, remember, is never focal. It tends to be more diffuse, and it is something which is a little bit more dangerous or lethal. Why is it so? It is because of this large potential space in which a lot of bleeding can occur. It can extend to the neck areas, and this can lead to hypotension, tachycardia, pallor, and all these vascular or hemodynamic complications. Encephalocele usually presents with a bony defect in the underlying skull wall and something bulging out of it. So there is a bulge with an bony underlying defect which is there. So this is what is an encephalocele. Now, if you look at these conditions, what is the extent? This is important to crack this particular question. Remember, a cephalohematoma is always focal. As we've discussed, it is limited by suture lines because where it is located, we have seen it is located below the level of the periosteum and it is limited by the suture lines. Therefore, caput succedanum can also be focal, but it is not limited by suture lines, right? It can be diffuse occasionally. Subgaleal hematomas, I just told you, tend to be diffuse. They are not focal, they tend to be diffuse. They are slightly dangerous. They can spread right up to the level of the neck because of the large potential area of this particular space there. Encephaloceles are usually focal but limited to the site of the underlying bony defect. So a part of the bone has not developed. So that is where the encephalocele is going to bulge out. Next, what is the clinical course? A cephalhematoma tends to increase after instrumentation, that is after ventouse or tend to, after delivery, that is after ventouse or application of forceps, and this may persist to around 2 to 3 months. Right, that is how the clinical course of a cephalhematoma is. Caput succedanum is self-limiting. It usually disappears completely in a few hours, not beyond that. Caput succedanum. Subgaleal hematoma clinical course can be lethal. It can be dangerous. Why? Because of the large space, large blood loss, which can give rise to tachycardia, pallor, altered state, hemodynamic compromise. Encephalocele clinical course, it is usually going to be a fixed herniation unless it is surgically corrected, right? So it is usually not progressive, may be associated with some neurological deficits because of the herniation of the brain parenchyma. Right, now let us come back to this question. See, what is the age? This is a 2-month-old child with a parietal swelling since birth. So the swelling was since birth, so one of these options, right? Now it is persisted up to 2 months. Tell me which of these options absolutely never persists. It disappears within a few hours. What is that? It is caput succedaneum. So this cannot be the answer. Why? Because caput succedaneum completely disappears in a few hours. So it disappears in a few hours. So it cannot persist for 2 months. Now, what is the clinical scenario? It is just a swelling. So it is a focal swelling, as you can see here, right? So this is the focal swelling which is there. Now, which of these conditions in the options that you see is usually never focal? It is, tends to be diffuse. Yes, it is subgaleal hematoma, which is usually diffuse. It is not focal. Here it is focal. This cannot be the answer. Also, subgaleal hematoma will not just present as a swelling because it is diffuse. It is also give rise to a lot of blood loss. It is potentially lethal and dangerous, right? So again, the patient here, the child here just has swelling, 2 months of age. So it cannot be subgaleal hematoma. Encephalocele, I have said, right, is almost always associated with a bony defect. Do you see any bony defect at this site? No, there is no bony defect. So there's no herniation of the intracranial contents out. So this cannot be encephalocele. And what is left? It is very likely to be a cephalohematoma. So that is likely to be the answer here. Right. So what we have done here is that we have studied these, 4 causes of pediatric, cranial swellings. We've looked at what they are, how they are formed, why they are formed, what is the extent, what is the clinical course, and then we have tried to rule out the options. The answer that remains here is a cephalohematoma. This is what it looks like. Yes. Yes. So this is cephalohematoma. All right. Now look at this. True about brachytherapy is the strength is inversely proportional to the square of the distance from source. Cancer cells and normal cells are equally sensitive to radiation. You have to identify the true statement. Small vessels are resistant. Oh, this is something which is something that needs to be looked into because we are not aware of which vessel is more sensitive, which vessel is more resistant. We are going to study that now. Small intestinal mucosa is more resistant. Now let us look at a few basics related to radiotherapy. Let us start with the inverse square law. The inverse square law defines a relationship between the intensity or the strength of the radiation beam, and it tells us that if the radiation beam begins at this point, that is the source, as you go away from it, we all know that the intensity or strength is going to drop with the increase in distance. But how does it drop? The intensity or strength is inversely proportional. So this is the inverse square law, is inversely proportional to the square of the distance from the source. As the distance increases, the intensity or strength of the radiation beam is going to drop. How? Inversely proportional to the square of the distance function, right? So this is what is the inverse square law. It is important in planning the radiotherapy when the beam is going to come from outside and the tumor is located at a particular depth within the body. We need to see what distance the radiation beam is going to travel, because as the distance increases, right, the strength is going to drop, with respect to the inverse square law like this. So that is where this comes into play. Another important concept I want you to know about radiotherapy, about radiosensitivity of organs and tissues, is the law of radiobiology. This is also called as the law of Bergoni and Tribondio. Name is not important, the concept is important. It tells us why a particular tissue is more sensitive to radiation as compared to the others. What does it tell us? It tells us that whatever tissue in the body that has the maximum undifferentiated cells, maximum undifferentiated cells, or cells within or in a state of active mitosis. So that organ or tissue in the body which has the maximum undifferentiated cells or blast cells or cells within a state of active mitosis, right? These are the tissues which are going to have the maximum radio sensitivity. Maximum radio sensitivity. Now let us compare a few tissues. Can you name a few tissues in the body which have the maximum undifferentiated cells or cells in active mitosis? Yes, it is the bone marrow, right? Where Hematopoiesis is constantly going on. There are a lot of blast cells, they are rapidly dividing. So maximum radiosensitivity. Anything else? Yes. Gonads. Yes. Gametogenesis, oogenesis, spermatogenesis is going on. So maximum radiosensitivity, a lot of division, blast cells, precursor cells, right? So gonads. Yes. Then mucosa. Mucosa of the lining, oral lining, right? Gastrointestinal tract, right? GIT. Why so? Because these epithelial, mucosal epithelial cells, if you remember, are constantly being replaced from the basal layers. So they are rapidly dividing, active mitosis, maximum radiosensitivity. So these are a few examples, right? Prototype examples of very high radio sensitivity. Just to quote a tissue which has a very low radio sensitivity is the CNS. So CNS has low radio sensitivity. Why so? Because does CNS have any undifferentiated cells or blast cells? No. Are the neurons constantly in a state of division or mitosis? No, not at all. They are highly differentiated cells with very minimal mitosis, and therefore CNS overall, right, neural cells are overall have very low radio sensitivity. All right. Now let us also take up this example to compare normal cells versus cancer cells. Tell me, which of these cells tend to be less differentiated? Sometimes cancer cells in a poorly differentiated tumor are less differentiated, right? Which of these cells, normal or cancer cells, tend to be actively dividing, are constantly in a state of mitosis? It is cancer cells. So when you compare normal cells versus cancer cells, it is cancer cells that have a relatively higher radio sensitivity. So remember, the underlying concept for you when you're preparing for these exams, right? It is very essential for you to know the underlying concepts, like the concept of law of radiobiology. Once you know that those tissues that have the undifferentiated cells or cells in active mitosis are more sensitive, you can apply it at n number of places in different factual topics to remember what is the radio sensitivity of various tissues, normal cells versus cancer cells, which tumor is usually more radiosensitive, which is less radiosensitive. All these things can be explained just by using the law of radiobiology. That is the importance of the concept of law of radiobiology. We'll apply this as we go ahead. Now we come to the vascular bed. Now if you look at the vascular bed, right, which of these components are more sensitive to radiation? Remember, it is the capillaries, small arteries, sinusoid spaces, and arterioles that have relatively high radio sensitivity. Why so? If you ask me, it is because in these small vessels, a very important function is played by the endothelial cells. These are metabolically active cells. They are regulating the flow across the capillaries, and therefore these endothelial cells are very sensitive to radiation, right? And therefore it is capillaries, small arteries, small blood vessels, arterioles which are more sensitive. As compared to that, it is the large veins, the aorta, major arteries. These are relatively less radio sensitive. These are relatively less radio sensitive. Okay. Now we come to this question. See, true about brachytherapy is strength is inversely proportional to the square of the distance from the source is exactly true. This is in fact what is called as the inverse square law. This is what precisely we have seen. This is true. Cancer cells and normal cells are equally sensitive to radiation is false. We just discussed this law of radiobiology. Cancer cell may be poorly differentiated, maybe is always rapidly dividing, so it is more sensitive to radiation as compared to a normal cell. This is wrong. Small vessels are resistant, no, is wrong. We've just discussed capillaries, small arteries, arterioles are more sensitive because of the endothelial cells which are metabolically active. Large veins, large arteries are more radio resistant. So this statement is wrong. Small intestinal mucosa is most resistant is also wrong. We just discussed. In the radiosensitive tissues, we discussed bone marrow, right? We discussed gonads. We discussed the bowel mucosa, right? So we've just discussed that these are constantly dividing, have undifferentiated cells. Law of radiobiology, they are more sensitive, right? whereas it is the brain neural tissues which are more resistant, they are less sensitive. So therefore true about brachytherapy is yes. So A is the correct answer over here. The fun here is that though we have cracked this entire question, we have studied this concept, the question uses a word. What is that? Brachytherapy. And there's nothing in these options related to brachytherapy. Yeah. So we've not even discussed what is brachytherapy. We've just discussed a few concepts about overall radiotherapy and we've cracked this question. Because there's this word brachytherapy, let us quickly revise by using an animation the various types of radiotherapies. Now, because this word brachytherapy has been involved here, let us look at the various types of radiotherapies quickly in an animation format. Based on the mode of delivery of radiotherapy, radiotherapy can be external beam radiotherapy or teletherapy. Tele means distance, means what? The radiation source is kept at some distance from the patient's body. Where is it kept? It is kept in a machine. There is a lung tumor that you need to irradiate. There is a radiation source, as you can see here, within the machine. So radiation source is placed at some distance from the patient's body, right? A beam is going to come out from this particular site and that is going to enter into the patient's body, and that is how the tumor is going to be irradiated. This is what is called as teletherapy. Right now, what are the various types of teletherapy? There are two main components which are used in teletherapy. What are those? Either it could be a cobalt 60 machine or it could be Line-X. This is the most common type of radiotherapy which is used, right? So let us explore it a bit more. Let us probe it a bit more. So cobalt 60 machines are commonly used. What are cobalt 60 machines? Inside this machine, there is a lead block. Inside this lead block, there is a source of cobalt. There is only a slit like opening in that lead block. So though this cobalt is going to emit radiation in all the directions, the lead is going to block it. So the radiation is going to come out only from that slit like opening in the form of a slit like beam. And it is this beam that is going to enter into the patient's body. Cobalt 60 machines are not very efficient. They are very difficult to operate. Yes. Why so? It is because you have to handle this cobalt, which is a radioactive agent. Cobalt 60 is an artificial radioisotope. You have to store it in the department. You have to put it in the machine. A lot of handling of cobalt 60 has to be done. So this is going to give rise to a lot of radiation exposure to the department personnel, right? So the person working in this particular department is going to handle all this cobalt. So radiation exposure to department personnel is very important issue. Another issue here is that it is not a very efficient working machine, right? If I want to increase or decrease the intensity of the cobalt, I need to open up the entire machine, remove or add some more cobalt, again assemble it. So the functioning is not very efficient. To overcome these disadvantages of cobalt 60 machines, newer machines are now used, right? And what are these called as? These are no longer cobalt 60 machines. These are called Line-X. What are Line-X? So Line-X is nothing but an abbreviated term for linear accelerators. So what are Line-X? Line-X are nothing but linear accelerators. What are these? They are nothing but X-ray tubes. So if you see this, see, Line-X are nothing but modified heavy duty X-ray tubes. So what are these? Let us revise an X-ray tube. If you remember, there is a tube housing, there is an oil bath, there is a tube envelope, right? Within it, there is vacuum, there is a cathode, there is an anode. When we pass an electric current through the cathode, what is going to happen? Electrons are going to release, right? These electrons, negatively charged electrons, are pulled towards the positive end anode. They hit the anode, X-rays are produced. So linear accelerators are nothing but X-ray tubes. What is going to happen? At one end, there is an emitter of electron. Like an X-ray tube, electrons are emitted. They are accelerated towards the anode, but they are accelerated by a very, very, very high degree. So it is called linear accelerator. These highly accelerated electrons, when they go and hit a heavy metal target, what is going to happen? Right? When electrons hit a heavy metal target, X-rays are going to be produced, but these X-rays are going to be very high energy X-rays. So what are Line-X? Line-X are nothing but modified heavy duty X-ray tubes. What is the radiation output which is coming out from Line-X? These are high energy X-rays. Occasionally some electrons also come out. Do you realize that we have not used any radioactive source in Line-X machines? What is the radiation output from Line-X machines? The radiation output from Line-X machines is nothing but high energy X-rays and a few electrons, I've said. There is no radioactive source which is used here, isn't it? Why? Because it is just an X-ray, tube, isn't it? So there is no radioactive isotope, no handling, no department personnel exposure. There are simple knobs on the machine. If I turn those knobs, I can increase or decrease the strength or intensity of these beams. So they are very easy to operate and configure, right? Now this is about external beam radiotherapy or teletherapy. We have studied cobalt 60 machines, right? So radiation beam intensity shape can be modulated by using filters or collimators. Now we have studied teletherapy, cobalt 60 machines and Lionax. When we look at teletherapy, when the radiation beam is going to come from outside, remember that some normal body tissues are always going to be exposed, right? So when a radiation source is placed at some distance from the patient's body and the radiation beam is going to originate from that particular source, it is going to enter into the body, right? Along with the tumor, some normal body tissues are always going to be exposed. So this drawback of teletherapy is something which is a limitation of this particular technique. What is that limitation? The limitation is that exposure to normal body tissues always occurs. This cannot be avoided when we use teletherapy. So therefore there is a newer type of method of delivery of radiation. And what is that? It is not teletherapy or external beam radiotherapy. It is called brachytherapy. What is brachytherapy? Brachytherapy is when the radiation source is not placed at a distance from the body. It is placed either on the body or within the body itself. How is it possible? So what is brachytherapy? Let us look at the various forms of brachytherapy now. Brachytherapy can either be interstitial, so radiation source is placed on the body or inside the body. Based on where it is placed, there are different types of brachytherapy. What is this interstitial type of brachytherapy? Interstitial means within the tissue or within the tumor. Radiation source is placed within the tumor directly. How is it possible? Let us consider an example, CA prostate. Now prostate, we all know, is located deep within the pelvis, as you can see here, very close to the urinary bladder, very close to the rectum, right? Surrounded by the pelvic bones. Rectum, urinary bladder are very radiosensitive. So irradiating the prostate gland from outside is a problem. So what do? What we do is interstitial brachytherapy. So what we do here is, by doing a transrectal ultrasound, by visualizing the prostate gland well, we insert empty metallic shells within the prostate gland. Once we put up these shells within the prostate gland, the department personnel goes away. There is a computer, you can say sort of a robot, which comes into play, and this was also a NEET-PG question which was asked. This robotic technique is what is called as a remote after loading. So the loading of radioactive element is done remotely after these shells have been placed. Therefore, it is called remote after loading. So these, empty shells are used as reference points by this remote after loading technique robot, which goes into these empty metal shells, and all these metal shells are now going to be filled up with the radioactive element. Once the radioactive element is introduced, the element is chosen in such a way that the radiation is coming from it is going to have a penetrating power in the body only for a few millimeters. So what is going to happen? Once these radioactive beads are placed here, they are going to emit radiation. So the tumor is going to be exposed from the within. The surrounding normal body tissues will not be exposed. This is called interstitial type of brachytherapy. Because the limited penetrating power of this radiation beam is very limited, tumor is exposed, surrounding normal body tissues are not exposed. This is called interstitial type of brachytherapy. Now, right, so surrounding normal body tissues are not exposed or very minimal exposure is there. Now there's another technique of using brachytherapy, and that is what is called as intracavitatory brachytherapy. What is intracavitatory brachytherapy? So intracavitatory brachytherapy is when the radiation source is placed within a naturally forming cavity or natural cavity within the body. So like for example, CA cervix. Cervix is again deep within the pelvis, close to the urinary bladder, close to the rectum, very difficult to irradiate from outside. So what we do, a radiation emitting device is basically placed within the cervical canal, and it is going to emit radiation. The penetrating power of this radiation is going to be very low. So what is going to happen? The cervical cancer is going to be irradiated from the within, right? Whereas the surrounding normal body tissues are not exposed. So when the radiation source is placed in a cavity within the body, it is called intracavitatory type of brachytherapy. So we have seen interstitial within the tumor, intracavitatory, that is within the cavity. There's another type of brachytherapy which is called as mold type of brachytherapy. What is this mold type of brachytherapy? It is used for superficial cancers like penile cancers or say squamous cell carcinoma at the nail bed. So there is a squamous cell carcinoma at the nail bed. What is done simply is that a cap of a radioactive element is prepared and the patient simply wears this cap on the tip of the finger. So what is going to happen? That the tumor is going to be exposed, but the rest of the normal body tissues are not exposed. So this is what is mold type of brachytherapy. So we have seen what is called as teletherapy, in which, or external beam radiotherapy, we have seen cobalt 60 machines and Linacs, and we have seen brachytherapy, in which we have seen interstitial, intracavitatory, mold type of brachytherapy. The advantage of brachytherapy is that the radiation exposure to the normal body tissues is extremely minimal, right, because of the limited penetrating power of the radiation. There is another way in which radiotherapy can be administered, and that is what is called as systemic radiotherapy, intravenous administration of radioactive elements. Say for papillary thyroid cancer, it is iodine 131. When this iodine 131 is injected into the body, it is going to be diffusely scattered in the bloodstream, in the systemic circulation throughout the body. But can you tell me in what organ iodine is going to be taken up actively? It is going to be taken up actively within a few minutes, entirely within the thyroid gland, isn't it? So once this iodine 131 is concentrated within the thyroid gland, it is going to emit radiation. The papillary thyroid cancer is going to be irradiated, and that is how the tumor cells are destroyed. So intravenous administration of radionuclide is called systemic radiotherapy. Like iodine 131 is used for papillary thyroid cancer, there are some other important indications in which systemic radiotherapy can be used. What are those? So phosphorus can be used in the treatment of polycythemia rubra vera. Phosphorus 32 is used in polycythemia rubra vera. Samarium 132, strontium 89 are used for treatment of painful bone metastasis because they'll get localized within the bones and thus irradiate the metastasis there. So what we have looked at in this beautiful animation series is that we have seen what is external beam radiotherapy or teletherapy, cobalt 60 machines, Linacs, how Linacs are just modified heavy duty X-ray tubes. We have looked at brachytherapy, interstitial for CA prostate, intracavitary for CA cervix, and we have seen mold type of brachytherapy for superficial cancers, and intravenous or systemic radiotherapy, iodine 131 for papillary thyroid cancer, phosphorus for polycythemia rubra vera, samarium, strontium for bone metastasis. Well, friends, I hope you liked this animation. I hope you liked this short and crisp discussion of questions. Believe me, this was not all about radiology in the NEET-PG exam. There were around 8 to 10 radiology-based, image-based questions. But to avoid repetition, I've just restricted myself to these few questions. The other questions, like the hydatid cyst or the obstetrics or gynecology part or the orthopedic radiographs, CTs which were asked, this is something that will be covered in utmost detail in surgery, orthopedics, medicine, pediatrics as well. Well, friends, if you've given this NEET-PG exam and you did not do well, remember, you feel as if you failed to get a great rank in this particular exam. But don't think of it that way. Think of it as an opportunity to begin again, and this time more intelligently. What do I mean with that? Believe me, those who got these great ranks, if you look at these topper interviews, if you look at posts on your Marolinks group, or your Facebook social media groups, if you look at these genuine rankers who got these really double digit or great ranks in these exams, there is something that these students did differently in these exams, isn't it? To be a winner, you need not always do different things. You just need to do things a little bit more differently. Go through these interviews, go through these posts, try to identify what more you can do, what different you can do, rather how you can do things differently. How can you plan your revision more efficiently? How can you sequence the various subjects when you plan your revisions? How could you deal with volatile topics better, right? All these things will add up to your preparation this year. We are all here with you. The purpose of coming out with these discussions is to give you a brief outline of how the questions are asked, how to crack them, how the allied topics on which questions could be asked. We could discuss them with you. And that is what the purpose of these discussions is. I want you to believe in yourself and keep trying, keep trying, keep trying. and ultimately you'll get that dream branch of yours. We are all here with you. All the very best. Thank you.